I'm really excited for our speaker today. I'm very excited to hand things over. I'm welcoming Alicia Gomes today as our speaker. I've actually known Alicia for many, many years, and I deeply appreciate her dedication to this community. Alicia is a licensed genetic counselor and assistant professor at the University of Alabama at Birmingham. With more than a decade of experience in medical genomics, she currently leads the Genetics and Genomics Graduate Certificate Program and serves as a key coordinator for the neurofibromatosis and schwannomatosis variant curation expert panel. That's a lot of big words, but mainly Alicia is a wonderful teacher, and she's here today to talk to us about what can be a very complex topic when we think about NF and schwannomatosis. And I'm happy to turn things over to you, Alicia. Take us away.
Thank you so much, Kate, and hi, everybody. I'm very excited to talk to you today about mosaicism. It's especially a topic that I'm interested in, but can be very complex for so many people to understand. So I'm hoping today we can break this down in a way that feels more digestible for everyone. Let me go ahead and share my screen. So as Kate mentioned, my name is Alicia Gomes. I am a certified genetic counselor by training, currently an assistant professor at the UAB School of Health Professions, but I've been working in the NF and schwannomatosis space for quite a number of years. My goals for today are to really focus on four main topics that come up. What causes mosaicism and segmental NF and schwannomatosis? How is mosaicism diagnosed? What does that mean for the family? And how does this help with a person's care if they have been diagnosed with mosaicism? But I think to do that, we first have to start with some genetics 101 just to get us all on the same playing field. So, what we're talking about here for NF1, NF2, SMARCB1, and LZTR1 is that these are genes. And the genes are the instructions that make us who we are, that our body reads to grow and function. These genes are bundled tightly into these structures called chromosomes. And those chromosomes are in the middle of each of the cells that are in our body. And so when we talk about the gene, these are all genes that everybody has. But when we talk about having a genetic disorder, what we're really talking about is that there is something different about the letters that make up that particular gene for a particular person. So with that being said, when we think about the genes associated with NF and schwannomatosis, there are two main chromosomes that we're thinking about. For NF1, this is chromosome 17. And for NF2, SMARCB1, and LZTR1, they're actually all neighbors on chromosome 22. Why are they numbered this way? So we take all of these chromosome structures and just list them out and line them up from largest to smallest, and that's how we get to 1 through 22. And then we all have a copy of sex chromosomes, XX that makes us female, or XY that makes us male. And so the gene for NF1 is located on this 17th chromosome. And like I mentioned, the three genes for schwannomatosis are all on this bottom end of chromosome 22. That matters, and we'll talk a little bit more about that in a moment. So let's get to the meat of what we're talking about today. What causes mosaicism and what causes segmental presentation? We have to think back to embryogenesis. And so we know that we all start with an egg and sperm. They each carry half of our genetic material. So when I showed the pictures of the chromosomes, you saw that there were two copies of each of those chromosomes. That's because one comes from the mother and one comes from the father for each of those chromosomes. And those are fused into one starting cell. The way we grow into an embryo is that one cell divides into two, which then divides into four, and so on and so forth until we have enough cells to start making an embryo. When we have mosaicism, as that one cell is then copying itself, and then those cells are copying themselves, what has taken place is that there has been a gene change that has taken place. So when it's retyping all the letters of the NF1 gene or retyping all the letters of the LZTR1 gene, a mistake was made. Our body has the ability to fix those mistakes because it happens all the time. But when you see mosaicism, it means that a gene change took place and it was not corrected. Because of that, the cell that has that initial gene change then goes on to get copied, and now that same gene change gets copied into every cell thereafter. So that means that this gene change took place after the sperm and the egg fused. So this was not a gene change that originally started in the original single cell of that individual. This is something that took place after fertilization. That's important because what we don't know is at what point during the embryo creation phase that the gene change took place. We know that we start with cells that are pretty open to be whatever. But as our body continues to grow, when we become an embryo and then a fetus, then our cells start to really decide what they're going to be in life. Am I going to be an arm cell or a leg cell? And so, depending on when the gene change took place, can then result in what do those cells end up being in the body. So depending on at what stage the gene change took place, it means that this could be affecting more cells or less cells in the body. And that's why when you see an individual who is mosaic, they may have a milder clinical presentation because less cells, therefore less parts of the body are affected. So let's talk a little bit more about that. So I've kind of mentioned here that you have fertilization, you start with one cell, that cell starts to multiply, and then depending on at what point during the embryo process the gene change takes place determines what type of mosaicism we're dealing with. The first type of mosaicism that I want to highlight is what we call generalized mosaicism. This means that if you looked at this individual, they have features in different parts of the body. And they may also have different types of clinical features. Maybe they have cafe au lait spots and neurofibromas. If we're talking NF2 schwannomatosis, maybe they have multiple schwannomas in different locations throughout the body. This is called generalized mosaicism. And that means that this gene change probably took place earlier in fetal development. Therefore, it has been copied more times and therefore affecting more parts of the body. You may have also heard the word segmental. So segmental is something that we think most about in NF1, but you can see it in other conditions as well. But this is now where we're saying that the features associated with NF or schwannomatosis are specific to one region of the body. So if it is only affecting the arm, or in this particular picture, it's only affecting the right side, this means that this is a mosaicism or a gene change that took place later in fetal development. And as a result, this gene change is affecting less cells in the body. And so because of that, now the clinical features associated with that condition are more isolated to one body segment. Last, we have something that is less frequent, usually less than 1% of scenarios, but this is what we call gonadal mosaicism. So we have the cells that are very specific to creating our eggs and our sperm. And sometimes the gene change can be present only in the egg or sperm creating cells. That means that none of the cells that create our actual body are affected. So these individuals have absolutely no signs or symptoms of the condition, but it's specifically their egg or their sperm cells that are affected. So that means that they have a risk to have multiple children who do have NF or schwannomatosis, but they themselves don't have any signs or symptoms. This is more rare, but we pick it up when we see an individual where there's no family history, but they have multiple children who have the condition and they all have the same gene change. So what causes mosaicism? This is just due to random occurrence of gene changes. To be honest, we all have gene changes in our body that just make us who we are. So a lot of times they get corrected, but when they don't, it's just now more important to know, is this gene change located in a gene that our body needs to function and grow? And is it in a location that can cause disease? And so there's nothing that we could do differently to prevent this from happening. It's just one of those random occurrences that takes place. So now that we have a better lens of what causes and what is mosaicism, let's talk a little bit about how mosaicism gets diagnosed for patients and families. In order to get a diagnosis of mosaic NF or mosaic schwannomatosis, it's important that you see a doctor who specializes in these conditions. The reason for that is depending on if you're in that category of generalized mosaicism versus segmental mosaicism, that can determine how they need to make the diagnosis. In theory, or in general, there are two different ways a diagnosis is made. The first is a clinical diagnosis. This means that you see the doctor, they can identify enough clinical features on you to say, yes, I feel confident that you have a diagnosis of NF or you have a diagnosis of schwannomatosis. From there, they may be able to identify this as mosaicism if all of the features are isolated to one segment of the body. That is what we call textbook distribution, because when you cut the body in half, perhaps it's almost as if there's an invisible line and the features don't cross over the midline. That's one of those hallmark things that specialists can pick up on that lets them know that they are more concerned about mosaicism. Perhaps it's even more refined and they can say, look, these features are specific to just one arm or one leg. And so that can also help them in feeling confident that this is a diagnosis of mosaicism. However, in many cases, it does require doing a type of genetic testing or getting a molecular diagnosis, so getting testing done in order to make this distinction and this diagnosis. I especially think about that when we talk about those generalized mosaic individuals, where they can have features distributed throughout their body, but maybe they're just presenting at a later age, or maybe they're presenting with a milder clinical presentation for the condition. And so to get a diagnosis of mosaicism molecularly, you have to undergo genetic testing for the genes that are of interest. And then you also have to have at least one clinical feature. So if they do gene testing and they find a gene change, but you're completely asymptomatic, they're not going to give you that diagnosis. So they do need to identify at least one clinical feature in order to make that distinction. How often does mosaicism occur? It's a really good question because for some conditions, we have a better handle on that. For others, we don't. With NF1, there's no specific percentage that we quote, but it is expected to be more prevalent than we originally anticipated. Part of the reason for that is it does take some very specialized testing in some scenarios to make that diagnosis of NF1 that's mosaic. And I'll talk a little bit more about that in a moment. For schwannomatosis, if we are talking NF2 related schwannomatosis, this is known to be a condition where you see a higher percent of mosaicism. The thought is that there's at least 30% of cases that are actually mosaic, But there's been more recent studies that have estimated that this rate of mosaicism could be as high as 60%. So this is a condition in a gene where we do have to keep our eye out for mosaicism for sure. When it comes to SMARCB1 related schwannomatosis, this is a condition where we do have a handful of cases that have been reported in the literature, but the percent is not expected to be as high as NF2. We're still learning a lot about that. For LZTR1 related schwannomatosis, to date, there have not been any known cases reported in the literature that I'm aware of, but so this is not a phenomenon that we've seen in LZTR1 related schwannomatosis. Thus far, when we've done the testing, we've been able to confirm that these gene changes have been in all of the individual's cells. So, if you're getting testing for NF or schwannomatosis, there are two different approaches that can be done. One is doing blood-based or saliva-based testing. These are really in the same bucket, so I'm grouping those together. The other is that they're going to need a biopsy or testing of affected tissue like tumor or cafe au lait spot or neurofibroma. And so let's talk a little bit about what that entails. In both scenarios, but I'm going to focus first on blood and saliva. You may hear them say that this is a sequencing test. In reality, there's a lot of different ways that you could get genetic testing done for NF and schwannomatosis. The first is single gene sequencing. This is a scenario where you have clinical features that make us think very specifically of one gene. I think about bilateral vestibular schwannomas, really makes us think about NF2. If someone has cafe au lait spots and neurofibromas, we're immediately thinking NF1. In those scenarios, we just need to look at the letters that are associated with just that one gene. So that's single gene sequencing. Sometimes an individual has a clinical presentation that can fit multiple genes. If someone is presenting with just cafe au lait spots and freckling, this can overlap with Legius syndrome. It's rarer, but still a possibility. So maybe we need to do a targeted panel that focuses on just specific genes. So we're going to read the letters of just those specific genes that we're interested in. You especially see this in the schwannomatosis space because of the significant overlap in the clinical presentation for NF2 SMARCB1 and LZTR1 related schwannomatosis if an individual is only presenting with schwannomas. Those two categories and buckets are the vast majority of how individuals with NF and schwannomatosis get testing. However, I want to mention exome and genome sequencing because these are some hot topic words. You may see them being used quite a bit in other genetic disorder spaces. For exome sequencing, it's almost as if you're just trying to look at the most important parts of our genome. So if I were using an analogy of a book, if I had a book that had references and a table of contents and an index, exome sequencing would be like only focusing on the chapters because that's where the important information is. As opposed to whole genome sequencing means that we're now looking at all of the letters that we can. So that means we may now start looking into the index. We may start looking into the table of contents. We're trying to look at as much as possible to look at as many letters, even if they're not necessarily the most important ones, to try to gain a diagnosis. Because NF and schwannomatosis are what we call established conditions, we have a clear gene that fits with the vast majority of the cases that we see. That means between single gene sequencing and targeted panels, you have a high detection rate. There is rarely a scenario that you need to move to exome and genome sequencing as your first step to make a diagnosis for these conditions. Some other words that you may have heard as a part of getting genetic testing is Sanger sequencing or next generation sequencing. Sometimes it's shortened as NGS. Both of these are just different testing technologies that we have in the lab that allows us to look at each different letter as a part of a gene. And so they can be very helpful in helping us to identify if there's a gene change that might be present or absent. Sanger sequencing has been our foundational testing approach. It is the oldest. So for individuals who have had testing maybe before the year 2014, you very likely had Sanger sequencing as a part of your testing approach. It is still a gold standard way of doing testing. And so it does not mean that because you had Sanger sequencing, you need a new test. Next generation sequencing is a testing approach that has more recently come aboard. You see it being most heavily used in individuals who had testing after 2014. The differences between these is just that it allows us, next generation sequencing allows us to look at multiple locations at one time in an individual. To give you a better lens, this is kind of what the out product looks like from those. So for Sanger sequencing, what it does is when we isolate the DNA from the blood, we pool it into one big read. And so this G, for example, represents all of the Gs that are located at that location in all of the cells that we got the DNA from. That means with Sanger sequencing, in order to identify mosaicism, we have to compare the size of this peak to any peaks that might be up under it or beside it to help us in deciding if mosaicism is present. This is slightly different from next generation sequencing, where you get a separate readout from the DNA of each of the cells that you are reading as a part of that test. The benefit of that approach is that you can see individually for each of those cells tested where there may be a gene change present or absent. This gives us an ability to quantify the percent of mosaicism that might be present in a sample. So your take home from this, I'm not expecting anybody to come back as an expert in sequencing technologies from this, but the point of this is that with Sanger sequencing, if you've had testing using that approach, the lab can very likely say that there is mosaicism. However, it may be more difficult for them to be able to give you a percent amount of mosaicism. Whereas with next generation sequencing, depending on the method used by the lab, they can, in many cases, give you a percent of mosaicism. So let's talk about the types of results that you get back. So when you get blood or saliva-based testing, it's going to come back in one of three buckets. If it comes back as positive, that means that a gene change has been found in the blood or saliva cells. And that's important because these cells represent what we call our germline, meaning that if we see a gene change in our germline, in our blood cells, it is very likely present in all of our cells. So if we see it at 100%, that's considered classic. That's not mosaic. If there's a concern of mosaicism, it may be noted on a positive report that says this diagnosis is suggestive of mosaicism for this condition. And it's based off of, like we talked about, how many counts or what the peak looks like from the testing that was done. Another type of result that you can get is what we call a variant of uncertain significance. This means that a gene change was found, and that gene change could be in a small percent or in all the cells. But more importantly, the gene change that we saw, we actually don't know if it causes disease or not. And so it is a variant of uncertain clinical significance. So it doesn't matter what percent they saw it at. If they considered a VUS, it does not give you a diagnosis of the condition by itself. If you get a report back from blood or saliva that says negative, that means that when they looked in the blood or saliva, there was no detectable presence of that gene change. depending on the technology. Some are more sensitive than others, as we've already kind of reviewed. And so that doesn't mean that it's not present. It's just not present at a level that they can detect. Or if you have mosaicism that is affecting specific cell types because it happened later in fetal development, then it doesn't matter how deep you test blood or saliva, you'll never see the gene change because that's not the type of cell that went on to be made from the cells that had the gene change. So for that reason, when it comes to mosaicism, it sometimes requires us to do testing from affected tissue or tumor. So for NF1, this is what we would expect to see. So as I mentioned, we kind of talked about you have a gene change that took place at some point in one cell. That cell went on to divide to make more cells. And so that gene change should be the driving gene change for any of the clinical features that you see associated with NF1. However, to get features, you actually have to have a gene change on both copies. So as a reminder, we have two copies of our NF1 gene in all of our cells. One we get from mom, one we get from dad. So if there is an underlying gene change in all of the cells that make our skin, for example, over time, we all acquire gene changes from just general exposure to life, the sun, food, everything. And so because of that, we can just acquire a second hit. If we get a unique second hit in a particular cell, and that means that both copies of our NF1 gene are no longer working, that then gives us the place and space to start developing features associated with NF1. And so that's why in cafe au lait spots, you can see two hits, and in neurofibromas, you can see two hits as well. And so if we're doing genetic testing, looking for mosaicism, we would want to look at multiple biopsies, so more than one cafe au lait spot or more than one neurofibroma, so that we can confirm, do we see one gene change that's exactly the same in all of those affected tissues, and then one gene change that's completely different in each one. When we see that, so in this particular scenario, we have this gene change that's exactly the same in all of them, but then these additional red, green, and blue represent unique gene changes that have popped up in each of these different cells that made cafe au lait spots. Seeing this gives us confidence that this is mosaicism. When we don't see that first hit in the blood, so that means some cells have the gene change, some cells do not. That is, by definition, mosaicism. In schwannomatosis, is slightly different. With schwannomatosis, as I have already mentioned to everyone, NF2, SMARCB1, and LZTR1 are all neighbors on chromosome 22. So instead of having gene changes that are just affecting one gene, we can see gene changes that are actually affecting all of these genes or some of these genes. With NF2, we do tend to see that the gene changes are more specific to just knocking out both copies of the NF2 gene. So in the same scenario that we talked about for NF1, you can see where there's a common gene change in all of these different tumors in NF2, but then in each of these tumors, there's also a unique gene change, and they're specific to the NF2 gene. So seeing a common NF2 only gene change lets us know this is mosaicism for NF2. Alternatively, with SMARCB1 and LZTR1 schwannomatosis, our genetic testing is more complicated. The point of what I want you to appreciate out of this is that it actually takes knocking out both copies of either the SMARCB1 or the LZTR1 gene, and knocking out both copies of the NF2 gene in order to get a diagnosis of SMARCB1 or LZTR1. And so when you have mosaicism for these conditions, you would expect to see that this gene change is not present in blood. So that might be the case for SMARCB1, where we've seen that. And in principle, that's how it would work for LZTR1. As I mentioned, to date, we don't have any mosaic LZTR1 cases. So what does mosaicism mean for my family? When we think about mosaicism, we have to first think about these conditions as a whole. So in a traditional classic case of NF1, classic case of schwannomatosis, these are conditions that we consider autosomal dominant. That means that it only takes one copy of the gene to be affected to have the condition. And because we pass down half our genetic information each time we have a child, it means that we would have a 50-50 chance of having an affected or an unaffected child. Doesn't matter if it's a male or a female. But when we are thinking about mosaicism, not all of our cells are affected. And so, because of that, we can see different clinical presentations. A lot of times when an individual is mosaic, they are the very first person in the family that is presenting with signs and symptoms. That is because the gene change started in them after fertilization, so it was not something that was being passed down from generation to generation. However, if a mosaic individual, so let's say this gentleman right here, my squares are males and my circles are females. So let's say this person right here had mosaicism. And let's say that one of their sperm cells also has the gene change that they are mosaic for. Well, if that sperm cell goes on to produce a child, because it is going to now be in the very first cell that creates that fetus, when that one cell makes multiple copies, that means now that gene changes in all the cells of that individual. And so because of that, any child that's affected of an individual who is mosaic, that gene changes in all their cells, so they're going to have classic disease. My take-home points for you is that you can't pass down mosaicism. If you are mosaic and you have an affected child, that child is not considered mosaic, that child is considered classic for that condition. And they have a 50-50 chance of having another child with that condition. If an individual themselves is mosaic, we say up to a 50% chance to pass down the gene change, but we can't give you a specific number. So let's think about mosaicism in the family from those lenses. If you are the parent or a sibling of an individual who is mosaic, you're actually a general population risk to have an affected child. There's no increased risk for the parents or the siblings that they themselves would be affected. If you are the person who is mosaic, we would quote you up to a 50% chance to pass down the gene change, but we can't give you a specific number because we can't go through the whole body to determine what cells do and do not have a gene change. We do know that your clinical presentation could be milder based on whether or not and when in the embryo creation process the gene change took place. But it's not a guarantee that you will always have a milder presentation than classic disease. If you are the affected child of an individual that is mosaic, again, you are not mosaic. You have classic disease. And your clinical presentation would be in line with what we would expect and say for anyone who has one of these diagnoses. So you would be considered classic NF1, classic schwannomatosis. If you are the affected child of an individual that's mosaic, you have a 50% chance of passing this condition to your future children as well. So sometimes we hear people wanting to determine if they're mosaic and doing genetic testing because they want to have the option for genetic testing as a part of family planning. So what does that look like and what does that mean? If you don't have an established pregnancy, maybe you're trying to plan having a family. If you have general mosaicism, we would suggest that, or excuse me, for males, what we can do is test the sperm. So when we get a sperm sample, it includes millions of sperm cells. So that gives us a good lens of testing an option to see if we can quantify a percent of mosaicism for that gene change that we see in the sperm. Because the percent can be different in different cells based on when the gene change took place. Unfortunately, this is not an option for females because we only have so many egg cells at birth. And once you use that egg cell to do testing, it's no longer an option in order to use for future pregnancy. And so you can't get a large percent of egg cells that you can test and get a percent for. So you don't have that same option available. There are sometimes the option of what we call pre-implantation genetic testing. The way this process works is an individual would go through in vitro fertilization, or IVF, where the sperm and the egg of the affected individual and their partner are fused outside of the body. And then they allow the embryo to grow to a certain number of cells, and then they just take one of those cells and they test that embryo to see if the gene change is present or absent. Sounds like a great approach. However, for mosaic individuals, and even individuals who are just brand new affected individual in their family, there are some significant limitations in access to this testing approach. A lot of the upfront work that they have to do to be able to make this test an option, they just don't have the material to do it when an individual is mosaic or the individual is the first one in their family that is affected. So I say options vary when it comes to this PGT is what it's called, or pre-implantation genetic testing, because a lot of it depends on the gene change that you have and your percent mosaicism and just what lab you're working with and using. After conception, so there's an established pregnancy. If you're in the first trimester, there is testing that can be done for the fetus where they will take some of the cells from the placenta and they can do testing to see if the gene change is present or absent. Those same cells that go on to make the fetus are the same cells that are used to make the placenta. And so they can look at those cells to see if the gene change that was in one of the parents is also in the fetus. The same can be done in the second trimester as an amniocentesis. The way that process works is they take some of the fluid that is surrounding the fetus because the fetus is sloughing off cells, skin cells around them the same way we do, but they're in a closed capsule, so they're all right there in the fluid. And so they can take some of those cells and test them from the fluid and see if the gene change is present or absent. And then, of course, there's also the option of doing testing after birth. So after the individual is born, as a newborn or a child, if you wanted to do testing in order to determine if the gene change is present or absent, you can do that after birth as well. But to do and have good accuracy for all of these tests, the affected individual has to have already had genetic testing. So it's important that if you want to have access to any of these options, the affected individual has to have had testing first. So how does this help with my care? Why does it matter if I'm mosaic? For all of these conditions, it's important to just note and mention that mosaicism levels can be different in different cell types. If someone can give you a diagnosis of segmental NF, that means that we are zooming in further and further into the specific types of cells that might be affected associated with that disorder. And so sometimes you can see that these individuals may have less management or less specialist or less follow-up needed compared to individuals who have classic NF or schwannomatosis. For individuals who are more generalized mosaic, typically these individuals are managed more like a classic case because we can't, by looking at someone, predict what cells do and don't have the gene change. Another important thing is that if your provider, when looking at you, feels that you have segmental disease, then blood or saliva-based testing will never give us the diagnosis. We have to do testing of the affected tissue or tumor in order to make that diagnosis and that establishment. And so getting eyes on or having a specialist put eyes on your clinical presentation and then getting that diagnosis of mosaic or not mosaic can help them in deciding if you need less follow-up or the same amount, and in deciding what is the best testing approach for you in order to establish your diagnosis. I know we talked about a lot today, so I just want to leave you with my key take-home messages that if you don't pick up on anything else today, that I hope you got this from our conversation. The first is that segmental is just under the bigger umbrella of Mosaic NF. Mosaic NF means that you could have general mosaicism where it's all over the body, but just kind of less than classic, or it could be segmental where it's isolated to one body segment. But all of that is mosaicism. The second is that the clinical presentations for mosaic NF and schwannomatosis can be milder, but in some cases they can present in the same presentation as someone with clinical NF and schwannomatosis. And so for that reason, it can take genetic testing before someone can get an established diagnosis of mosaicism. Blood or saliva-based testing may not pick it up. And as a result, for some individuals to get that diagnosis of mosaicism, it requires unique testing approaches, like testing tissue or testing tumor, in order to make that diagnosis. We still quote up to a 50% chance of passing down NF or schwannomatosis if an individual is mosaic, because we are not testing every cell line in the body, and therefore we can't quantify what percent of the eggs or sperm are affected. Prenatal genetic testing options vary if you have mosaicism. And so it is important that once the specific gene change has been identified, that a genetic counselor helps you find different labs that offer these prenatal testing options to see what options are available to you based on your percent mosaicism and the type of gene change that you have. And clinical management will be based on your clinical features. If you are someone that has a more generalized presentation, you may be followed very similarly to an individual with classic NF. And that's because we don't know what cells are and are not affected. Those that may be more segmental, depending on what body segments and how involved it is, you may have less follow-up that is involved. I hope this was helpful in giving you a broader understanding of schwannomatosis and NF1 as it pertains to mosaicism, and I'm very happy to take any questions that anybody has.
Fantastic. Thank you so much, Alicia. That was wonderful. Okay, so I'm gonna spotlight the two of us here. We get to share the spotlight. And I have several questions that have come in that I thought were really interesting. So
Okay.
kind of get right to it.
Yes, I love it.
Okay, so the first one that I love this because, you know, I had to look up what something in this question meant because our patient population is brilliant. But it says if an NF2 frame shift variant is found in the tissue of a singular vestibular schwannoma, at a VAF, that's what I had to look up, of 28%, but not in blood or germ cells. Does that point toward mosaicism or is it unknown? And I think the crux of the question is this next part, which is there a way to know prior to a second tumor if it will be generalized or segmental mosaic, I guess is really the question.
Fantastic question. I'm gonna break the question down for everybody else as well. So
Great.
what this person is asking is if you have a gene change that has been seen in the tumor, but it's present at a lower percent. So in this case, it was 23, 27. What was the percent?
28.
28%. So if you have a gene change that was present in a tumor at a percent less than what we'd expect for germline, is there a way to confirm and know that this is mosaicism for the condition without doing testing in additional tumors?
Mhm.
Fantastic question, because when we're talking about tumors specifically, even in vestibular schwannomas that you see in the general population, so individuals who do not have NF2 related schwannomatosis or schwannomatosis in general, you can still see NF2 gene changes. That gene is just very responsible for making vestibular schwannomas.
Mhm.
So seeing an individual gene change, especially at a lower percent, by itself raises no red flags. What I would want to see is that that gene change is consistent and present in different cells or different tumors, or I see that both copies of the NF2 gene have been knocked out.
Mm.
Then I'm more concerned that we're dealing with NF2 related schwannomatosis. And then also looking at different tumors can also help me feel more confident that we're talking about mosaicism for NF2. I hope
Great.
that answers that question.
Yeah, I mean, I understand more than I did a minute ago. Thank you.
Good.
Okay, so we have several questions. So for anyone, I just want to say quickly that if your question is not addressed in this conversation today, we track and keep all of these questions, and I can follow up with folks after. So I just like to tell
Yes.
people that. Okay, so the next one says, I have a male family member who was recently diagnosed with mosaic NF2. The mutation was found in 2 tumor samples, not in the saliva. He's thinking about having a family and wondering about the chance that he could pass this on. This person also said that they're reading that in the literature, it looks like the chance of passing it on is less than 1%. But you talked a little bit about this today. And so I thought maybe this would be sort of a real life example to give you the chance to sort of dig in on these risk factors.
Absolutely. So if you have an individual who has a confirmed diagnosis of mosaicism because they saw the same gene change in multiple tumors, not present in blood or saliva, they have an established diagnosis of mosaicism. The first question that people always want to know is, well, what is the chance that I
Mhm.
could pass this down? For males, we could do testing in sperm. But what I always like to zoom back on is that no genetic testing will be able to tell you that there is 0% chance. Because even if they do testing and they don't see anything, there's always limitations to the testing technology themselves. So let's say if you did testing at UAB and the cutoff is 5%. So we said, all right, if we see it, it's present in 5% or higher. If we
Mhm.
don't see it, it means it's at 5% or lower. Well, how do those numbers feel to you as a patient? If you knew that your percent to pass it down was 5%, would you feel comfortable moving forward with natural conception? If so, then you could do this testing, because then that testing is giving you a piece of information where you're like, okay, as long as I know it's not higher than 5%, I'm fine.
Mhm.
However, if you feel like I don't care what the percent is, whether it's 1%, 5%, 10%, I would still want to know for the embryo or for the fetus, then you need to not necessarily do testing of the sperm, but instead consider what type of testing options are out there for you when it comes to pre-implantation genetic testing or testing during the pregnancy. And so that's where, if you're interested in those preconception testing options, you would need to work with the reproductive endocrinology and infertility groups and specialists to find an IVF lab that you could work with. You would share your gene change ahead of time with the PGT lab, and then they would be able to let you know. Actually, they're going to want more than just your gene change. They're going to want your gene change. They're going to want sample from you, sample from your parents, sample from your siblings. So it means that if, depending on your family dynamics, these testing options may or may not be available. So it requires a lot before they can say yes or no, whether or not they can help build a test for you. So that's how that process works. For males, I always start with a family conversation of, is there a percent that if we knew that if it's at this percent or lower, we would feel confident, then consider sperm-based testing. But if you feel like there's no percent that you would want to feel confident with, then it's kind of that next step that you need to consider.
Yeah, thank you so much. And this is just another plug for, when you're thinking about genetic testing, whether it's for yourself or for your child, et cetera. This is why I always recommend to families to meet with genetic counselors, that it's not a simple blood test where you just get a simple answer. It's very complex
Exactly.
and there's lots to think about. That was
Yes.
very helpful, Alicia.
Yeah. And we help put it in perspective, which is good.
Yes, exactly. So this next question is sort of thinking about a similar question about testing, but from maybe the opposite end of the spectrum, which is that this attendee said that their blood was sent to UAB for NF2 genetic testing. 1% of my blood cells tested positive for NF2. I was 52 when the tumors were found. My children are 24, 23, and 20. Would you recommend that they get tested for NF2? And if so, how would we go about that?
Yeah, so good questions. One, if the gene change was found in 1% of your blood, that means that this is likely mosaicism that happened earlier in the fetal development and growth process. So, what we would be concerned about for your children is that they would have classic NF2. We're not concerned about mosaicism for them. So they can get targeted testing for the gene change that was found in you, even though it was only found at 1%. And so if they are in their 20s, they're right around that age where we would expect to start seeing some signs or symptoms. So if they have made it to this age with no signs and symptoms, it can be reassuring. But if they want that kind of sign sealed confidence that they did not inherit your gene change, they can get a quick test. It's a shorter turnaround because they're only looking at that one gene change to say yes or no is present or absent. We would not expect them to acquire a new gene change unless they're at general population risk. And so for what has been passed down from you, it's just a yes or no. Is it present or absent?
Excellent. Thank you. That's very helpful.
Yes.
Okay, so this one's interesting. I might have missed this, but this commenter said that the up to 50% recurrence risk, so that you must have mentioned that, seems to be at odds with papers from Gareth Evans. I don't know how much you want to speak to that or not, but they just asked if you could discuss that further. For those of you who don't know, Dr. Evans is a very famous NF2 schwannomatosis researcher out of the UK who's published a lot of work on this.
Yes. So Dr. Evans has done a lot of great work with looking at the actual percents that have been seen in different family studies that have been done in the UK Manchester area. Those are good numbers to consider and think about for sure. As a genetic counselor, we like to kind of give a overarching consideration, especially as I'm thinking about scenarios for NF1, NF2, and schwannomatosis, that it could be up to 50%. So in a specific scenario for a specific patient, we may start to look at those papers and say, okay, well, based off of what we see in this cohort of patients, we're actually estimating the likelihood of passing it down to be X percent. But we like to see establishment of that information long term over multiple papers, over multiple cohorts of different groups of individuals before there's kind of an establishment of saying this is the likelihood of this being passed down. The general community thought is that it's very low.
Yeah.
My approach to you as a genetic counselor is that it's going to be up to 50%.
That makes sense. Thank you. And I've heard questions like that before, which is why I knew it would be a helpful response. This next question, this is actually the last one that I ask. So again, to everyone who has had questions, we will follow up. Like I can always work with Alicia to answer a question
Happy
after the
answer.
fact. Yeah.
Mhm.
So, but this one I thought was interesting. So the question is specific. This attendee shared the specific genetic test result for their said a very young child under 2 who presents only with cafe au lait spots, but spread across the body. And they want to know if mosaicism can be excluded based on this. And so, without trying to read it, but it's a heterozygous for, C.1756. Like this is their genetic testing result.
Mhm. Mhm.
And I guess the question that I want to ask um, is there, if you've had the genetic test, you've had a blood test done, and you get this kind of a result, we're not looking at mosaic. Is that
Right. So if you've had testing more recently, which I'm expecting based on the fact that this is a 2-year-old and it
yeah?
was next
Oh yeah, this is
generation
a good
sequencing.
point. The timing.
Hmm. Hmm. So if it is, and it's a 2-year-old, so I'm expecting it's been more recently, that means that they were very likely using that next generation sequencing testing approach. Different labs have different cutoffs of what percent of mosaicism they're willing to put on a report versus their technology just isn't really good enough to really make that distinguishment.
Mhm.
And so if the report does not say mosaic, then the lab did not detect a percent that they would be concerned about mosaicism for. And so that individual is treated as if they have classic disease.
Okay.
If you
Yeah.
were tested earlier and it was Sanger sequencing, if you were using our lab, UAB's lab, it would have been on there if we were considering mosaicism because there were multiple testing approaches that were utilized in order to get that establishment. However, Sanger sequencing just in and of itself is more subjective. And so there can be scenarios where there's mosaicism that's present, but it could have been missed.
Yeah, that's super helpful. Thank you so much. Yeah,
Yes.
so many great questions. I really want to just give a shout out to our entire audience today for how engaged and just the really intelligent and thoughtful questions that you brought to the table. So thank you.
Yes,
And
this has
also
been
a huge thank
fantastic.
you to Alicia for being here and sharing all of her knowledge. This was incredibly helpful. I will release you from the spotlight and I'm going to do some last minute housekeeping, but is there anything, I don't want to cut, if there's anything you want to add or
No, thanks everybody for such great questions. Always happy to answer questions if you have any. The UAB lab, Reb Metzger is the laboratory genetic counselor. Always reach out if you have any questions about genetic testing and genetics of NF. We're always happy to help.
Yes, thank you so much, Alicia. I'm just going to do some quick housekeeping notes. Most importantly, I'm very excited to share that one of the reasons we invited Alicia to speak today on this is because CTF has developed some new materials that specifically provide education around mosaicism and segmental NF and schwannomatosis. We will share the link directly to those resources in the chat so that you can go and grab those. We'll also include those links in our follow-up thank you for being here email, but you can find them on our website, and just a nice way to kind of review and refresh what you heard here today. And so be sure to check that out. I also want to say that if you do not know about the NF Summit, which is our annual patient and family meeting, I want to encourage you to consider going and giving that a quick look on our website. You can actually find all the information about the NF Summit very easily at just nfsummit.org. And it is our annual patient and family meeting that is designed for connection and education and empowerment. And Alicia will actually be joining us to give another talk, so you can hear more and see her live and in person. So encourage you to consider joining us. The knowledge series is presented monthly with a new topic. Sometimes they are disease specific and sometimes they are not. But we encourage you to check out our educational events calendar, which we'll drop into the chat here to learn more and to kind of see what's coming next. In May, in honor of May Awareness Month, which is obviously a big month for all of us, and we want to honor the spirit of how the spirit of that there's a lot of power in taking action. So Dr. Ethan Lester will be talking to us about how community can move us from isolation to empowerment through making connections with other people. So we're very excited to bring him to that. And another opportunity to make connections would be to consider joining us for the NF Summit. So last plug for that. To make sure you continue to hear about everything CTF is doing, please consider signing up for our newsletter to kind of be the latest to hear everything. And yeah, and I hope you'll join us next month for May Awareness. And if you have any questions or anything about today that wasn't answered or that you didn't get a chance to put in the Q&A, please feel free to reach out to us. We're here to help, and we're happy to do that. So thank you again to everyone for being here, and we'll see you next month.